So we have Dr. ASHA Varghese. Yes, she'll be presenting on pigment dispersion and raised IOP following phakic intraocular lens implantation.
Good afternoon, all. I'll be presenting our case series on pigment dispersion and raised intraocular pressure following phakic intraocular lens implantation. So, posterior chamber phakic IOL is widely considered to be a safe and effective procedure to correct high myopia with very few complications. One of the less frequently reported complications is pigment dispersion, which can lead to raised IOP and, if unrecognized, can result in secondary open angle glaucoma. So the aim of our study was to describe the clinical presentation, course, and outcomes of patients who develop pigment dispersion following phakic IOL implantation. This is a retrospective case series over a 9-year period from December 2015 to December 2024. During this period, 241 eyes underwent phakic IOL implantation in our center. Out of these, 7 eyes of 4 patients developed pigment dispersion associated with a rise in IOP. For each of these patients, we evaluated the key parameters, including the preoperative characteristics and the clinical characteristics on developing pigment dispersion. This is the standard surgical technique followed in all our cases. We begin with the corneal marking, followed by creation of a side port entry. The anterior chamber is then filled with viscoelastic, and a clear corneal temporal incision is made through which the phakic IOL is inserted. And the lens is positioned carefully behind the iris, ensuring proper centration. And then the anterior chamber is then thoroughly irrigated with saline to remove the viscoelastic, and finally the wound is hydrated. So this is the preoperative characteristics of all the 4 patients who developed pigment dispersion. All were young adults between 21 and 24 years of age, 3 males and 1 female, and all had high myopia ranging from -6.75 to -15 diopters. Baseline IOPs were within normal limit, ranging from 10 to 14 millimeters of mercury in both the eyes. Gonioscopy in all the patients showed open angles, indicating no pre-existing angle compromise. Regarding the phakic IOL type, 3 patients underwent ICL, while 1 patient underwent IPCL implantation. Overall, all the patients had normal anterior segment parameters and normal IOP with no predisposition for pigment dispersion. So all the 4 patients underwent uneventful surgery, and post-operatively they received standard treatment with topical steroids and antibiotic drops. All had normal immediate post-operative IOP, best corrected visual acuity of 6.6 and normal slit lamp findings. These are the clinical characteristics at the time patient presented with pigment dispersion to us. The onset ranged from 1 to 4 weeks post-op, and 2 patients were completely asymptomatic, while other 2 presented with blurred vision, pain, redness, and photophobia. On examination, all the 4 patients had anterior chamber pigment dispersion, pigment deposition over the lens surface, and 4 to 6 mm pupil dilatation. In addition to that, symptomatic patients also had circumcorneal congestion, diffuse corneal edema, and AC cell reaction. There was also drop in vision acuity in symptomatic patient, and the IOP spike varied from 22 to 51 millimeters of mercury. Gonioscopy in both eyes of all patients showed dense trabecular measure pigmentation with open angles, confirming active pigment release. And ASOC demonstrated lens vault ranging from 808 to 1200 microns. In all the patients, the initial management focused on prompt IOP control. Oral acetazolamide was started in the acute phase, and 1 patient required intravenous mannitol for immediate IOP control. Topical AGMs formed the mainstay of treatment, which was tailored to severity of IOP rise in each case. Once the IOP stabilized, topical AGMs were gradually tapered over time. The duration of AGM use varied from 2.5 to 18 months, and all cases eventually achieved stable IOP off medications. Coming to the final follow-up findings, visual acuity was well maintained at 6.6 in all the eyes, and IOP remained within normal limits for all patients. There were no significant disc changes. Visual field testing was performed for all the patients and was completely normal, indicating no functional glaucomatous damage. Mild pupil irregularity persisted in all the patients. So coming to discussion, pigment dispersion is an uncommon complication reported less in the literature. In our case series, we had an incidence of 1.65%. The most possible mechanism in our series appears to be mechanical iris phakic IOL contact due to high postoperative vault. Although appropriate sizing was done pre-operatively, high wart in some cases may have contributed to pigment release. Our first line approach was topical AGM with systemic agents for rapid control, and in cases of refractory cases may require phakic IL explantation or even glaucoma surgery. However, in our series, all patients responded well to medical therapy alone and none required any surgical intervention. So to conclude, pigment dispersion is an uncommon complication following phakic IL implantation, but it's clinically important as it can lead to IOP elevation and secondary glaucoma if unrecognized. Early detection and prompt management can ensure excellent visual outcomes, and these cases highlight the need for careful long-term post-op monitoring even when the surgery is uneventful. These are my references, and thank you for your patient listening.
Nice presentation. So, any relation with your anterior chamber depth also in any of your
Anterior
case?
chamber depth was normal pre-operatively.
Uh,
Post-operatively also we had open angles,
all the cases.
all the cases.
Any of like 4 cases you showed that vault was within limit or it was slightly
Normal range of vault is 250 to 750. All had slightly high vault.
high because few cases having 800 and 850
Right,
also.
yeah. That might be one of the reason for the pigment release.
And you have treated with steroid also or only
A
with
steroid, it was in tapering doses. Post-operatively, we had given steroids in tapering doses.
any recurrence was there for after stopping steroid
no.
or
No, we continued AGM for a period of 8. In one case, it was 18 months.
Nice presentation. Just wanted to know, did this happen with any particular type of lenses? All four were of the
All-
same company?
3 were ICL and 1 was IPCL.
Okay.
IPCL is an Indian company and ICL is foreign company. Only one was in earlier reported literature. This complication has been reported in case of ICL.
1 second. Brother, can you please stop the sound of the timer? Mic is also not working, I think. Okay, why do you think that this happened
It
in
m-
these cases?
like previous literature has not reported any particular cause for the pigment release, but in our study, it might be a high vault can be a reason for the pigment release. High vault.
Is there any way where we usually look at the wall
Preoperatively,
preoperatively look at the AC
we
depth as
calculate the white to white distance and then we send for the company for the
Yeah.
lens. But
yeah.
the actual cause is not known.
So can you predict it before to avoid these happening or this thing later?
That we have to find a solution to see. I think doing a UBM can help to measure the correct white to white distance. So that might be helpful in predicting.
No other systemic causes were elicited in these cases.
No,
It was
no.
purely because of the
Purely-
vault and the surgical manipulation. Any systemic workup was also done in these cases to elicit why the inflammation could have happened. If the patient was on any immunosuppressants or any of those kinds, any personal
All
history
the
was taken.
patients were
Fit
free
and
of any.
no, not on any
systemic.
medication and no any history
Not-
of any
no,
significant.
One patient had thyroid disease. Other than that, all of them were normal.
Any uveitis workup or anything was done before or later on?
Later on,
No recurrences, you said.
no recurrences.
Hi, Asha. Good presentation. 2 questions for you. One question is, this study has been over a duration of 9 years, right? I'm sure there is a learning curve for the procedure. So these 4 patients that you saw, were they equally distributed for the 9 years, or it was seen during the initial
No, it was towards the end actually.
towards the
Towards
end?
the end.
Okay. And in similar lines as, Dr. Srinivas's question, autoimmune disease, it's pretty common now. We're all aware of it. Would you think of, kind of working up these patients with uveitis where surgery has gone really smooth? And of course, now you said there is no learning curve there. It's happened in the later cases. Would you think of evaluating them for autoimmune disease?
Yes. Yes.
Have you done that?
I have not done.
Not done that,
But
yeah.
I like
But the
probably
only
it would
thing she said was since there was only one occurrence.
one
uh,
occurrence.
Yeah. So this did not happen again after that. Is long period follow up is there of these cases? Of
One-
these 4?
Yeah, 1 year to 1.5 year follow-up is there.
So no recurrences you
No
have seen.
recurrence noted. Pigment release decreased, reduced over time, along with the control of IOP.
Okay. Why it came into my mind is you said that one patient had thyroid. You know, thyroid has associated autoimmune. It may not be always thyroid. So that's why. Thank you so much.
Thank you. Thank you.